We're working under very challenging times currently with the coronavirus pandemic, and there are a number of challenges which we're facing. One of the unexpected and tragic events which has occurred in our University of Toronto community is the unexpected and sudden death of one of our valued friends and colleagues, neurosurgeon Dr. Todd Mainprize. And to say a few words in honor of his memory, we've asked Dr. Nir Lipsman, assistant professor of neurosurgery at the University of Toronto and a good friend and close colleague of Dr. Mainprize, to say a few words in Todd's honor. Nir.
Thanks very much, Michael, and thank you to both you and Albert for the opportunity to speak and for remembering Todd in this way. It's incredibly sad to have to speak about this. We're still absorbing the news from last week, which is the death of Todd Mainprize. For those of you who don't know me, I'm a neurosurgeon at Sunnybrook Health Sciences Center in Toronto. Todd was our division head. I was one of his partners. Todd is a major reason why I came to Sunnybrook. He recruited me, and a big reason I wanted to come here was really him, and knowing that I'd be down the hall from a good friend. Todd was many things to many people. Much has been said in the last week about his legacy, his technical brilliance in the operating room, his skill with patients, his William Osler-like bedside manner, the ability to quickly put patients and their families at ease, really in their toughest time in their lives. Much has also been said about his being really a doting father to his 3 children, a loving husband, a brother, a son, a neighbor. What I want to highlight here is his generosity, his seemingly endless supply of giving spirit, as everybody who has known him, who is joining us here today, would easily testify to. So whether it's his time, he was never too busy for a question or an opinion, his expertise, and he never expected anything in return. And in many ways, he embodied for us what we do as clinicians, which is to give part of ourselves to our patients and expecting nothing in return. That's the way he lived. As any brief interaction with him, you walked away feeling like you were friends. So he was a member of Sunnybrook Surgery and the neurosurgery family. He is in the pantheon of Canadian neurosurgeons who really left an indelible mark on everybody who he trained and everybody with whom he worked and interacted. So he will be dearly, dearly missed by all of us.
Thank you. Thank you, Nir. Perhaps if we could just go to the next slide. And we might just kindly, out of respect, request a brief moment of silence to honor a fallen colleague and friend. Thank you. Well, Todd was a great educator and an advocate for education and for the trainees. And I know that Todd would have wanted us to continue on with an academic event such as we're hosting this evening in honor of our trainees and the academic and research excellence in the University of Toronto Spine program. And it's with that spirit in mind that we do continue with this evening's event, and also bearing in mind the memory of Todd Mainprize. So at this stage, I'd like to hand over the moderation responsibilities to my friend and colleague, Professor Albert Yee from Sunnybrook, and Albert shares the co-directorship of the U of T Spine program with myself. Albert, please.
Thank you so much, Michael. And I echo those sentiments. Todd was certainly a very good friend and valued colleague, and his generosity, his brilliance, I think, today we're sort of honoring his interests in education and really sharing that knowledge. So I also extend my appreciation and a welcome to Professor Studley for participating in our SpineFest this year. Several great talks last evening. I look forward to your talk later on this evening as well regarding chasing water uphill. So I've put a bit of a local background of Niagara Falls in the wintertime here as a bit of a background reference. And I think in the spirit of that education and knowledge exchange, we'll segue to the next part of our program, which includes trainee presentations. And the first presentation, I would like to call upon Spiros Karamandimis, who will be presenting on sensory cortical control of movement as a division of neurosurgery, a trainee, and a surgeon, researcher, investigator. So thank you so much, Spiros. And we'll turn the virtual podium over to you, and hopefully you'll be able to share your screen at this time. I guess as Spiros is taking over, we do have a function for either a chat or a question and answers. And so what we will do is we will basically have the round of 4 presentations and questions sort of at the end. So I'll call on our visiting professor, as well as questions that arise in the chat or question and answer function.
Good afternoon, everyone. That's in honor of Dr. Mainprize. I just also, as a trainee, want to say that on top of a great educator, phenomenal surgeon, Dr. Mainprize he was one of the best, if one of the strongest, if not the strongest advocate for residents in everyday life when you were rotating as a resident in Sunnybrook. We are going, as residents, we miss him and are going to miss him. So, moving on with my presentation, I would like first of all to thank the committee for giving me the chance to present today in this year SpineFest. My name, as Dr. Yee mentioned, I'm one of the 3rd-year neurosurgery residents, and today I will present some data that I believe redefine the neurophysiology of motor control. In the reductionist view of the act of walking, walking is often considered to be a very simple behavior consisting of rhythmic alternation of flexor and extensor motor pulse on the left and right sides of the body. However, to navigate the complex environment in which we live, the locomotor neural network in the spinal cord relies heavily on feedback control from the sensory fibers and feed-forward control from higher centers such as the visual cortex. Classical studies of mammalian movement control define a prominent role for the primary motor cortex. However, activity in primary somatosensory cortex neurons have been shown previously to have a modulatory role in locomotor activity in different species. Studies had interpreted this activity to be mainly anticipatory and exerted via the motor cortex. However, it is possible that the pyramidal neurons of the primary somatosensory cortex not only code spatiotemporal information, but they can also generate a motor response. To examine whether the primary somatosensory cortex, or SI, has a direct motor control on locomotion, we first recorded electrical activity from the pyramidal neurons of the SI in freely moving mice. On panel C, we have plotted both the velocity of the animal movements and the activity in the SI for the individual animals. And indeed, we observe a high degree correlation between the SI neural activity and the speed of movement. Further analysis indicate that the activity in the pyramidal neurons of the primary somatosensory cortex started prior to the onset of and peaked during the movement. Here, as you can see, the green line indicates the onset of the electrical activity in the primary somatosensory cortex, and the black lines indicate the onset of the movement. This data suggests that the SI contributes towards movement initiation and speed programming of locomotion. To further show that the primary somatosensory cortex can induce locomotion, we use the power of optogenetics and we photostimulate only the pyramidal neurons of the primary somatosensory cortex. This resulted in generation of field potentials in the lumbar spinal cord. As you can see in panels D and E, we also perform scaffold distribution analysis, which confirm that the activity observed in the lumbar spinal cord after photostimulation of the primary somatosensory cortex was not random, but indeed it was a result of the optogenetic stimulation of the pyramidal neurons in this area. These data support an efferent electrical connectivity between the primary somatosensory cortex and the lumbar spinal locomotor network. Next, we investigate whether the primary somatosensory cortex is directly connected to rhythmogenic neurons in the lumbar spinal cord. To do that, we perform a retrograde tracing, and indeed, as is indicated in the panel B, we found no neurons in the primary somatosensory cortex which are directly connected to the lumbar spinal cord. So to determine whether the somatosensory cortex is able to modulate locomotion, we electrophysiologically monitor the activity of the L2 and L5 ventral roots of mouse pups in an in vitro 3-split bath. This preparation, as it's shown here on the left of the screen, included the left cerebral hemisphere with the most of the motor cortex removed, the brainstem and the spinal cord of double transgenic mice which express channel rhodopsin in the cortical pyramidal neurons. The chamber A contained the brain and the brainstem, the B the cervical spinal cord, and the C the lumbar spinal cord. We initially induced locomotor-like activity by adding some neurochemicals in the chamber C. To preclude the possibility that the SI pyramidal neurons could be acting on the locomotor neural network which resides in the lumbar spinal cord through other supraspinal centers, we block any glutamatergic neurotransmission in a chamber A by adding an antagonist which is named kyanuric acid. Once we had stable locomotor-like activity, we photostimulate the pyramidal neurons of the primary somatosensory cortex, and this led to an immediate and significant increase in the frequency of the locomotor-like activity, as you can see in this panel. So far, this data demonstrate that the somatosensory cortex can act on the locomotor CPG through a descending corticospinal pathway independently of the motor cortex, brainstem, and other supraspinal locomotor centers. Given the lack of direct anatomical connectivity between the SI and the lumbar spinal cord, we set to examine the pathway that connects the somatosensory cortex with the locomotor CPG. Previous work has shown that the cervical spinal cord receives input from the somatosensory cortex. Indeed, our anterograde tracing data from the SI pyramidal neurons reveal, as you can see in the panel C and D, dense innervation in the intermediate gray matter at the cervical level. These findings, along with the previous findings, made this region a particularly compelling candidate for the relay center between the SI and the locomotor CPG. To investigate this, we went back to our previous preparation, and this time we block any excitatory neurotransmission by adding kynuric acid in the chamber B. Following the addition of the kynuric acid in the cervical compartment, photostimulation of the pyramidal neurons of the primary somatosensory cortex had no effect on locomotor frequency, as is indicated in this panel and also indicated in the graph. So having established the pathway, then wanted to investigate the role of this sensory cortical pathway in awake adult mice. To this end, we employed a chemogenetic approach in order to be able to transiently activate or silence in the same animals the pyramidal neurons of the somatosensory cortex, which project to the cervical spinal cord. The experimental paradigm to achieve this goal is depicted here, but for the economy of time, I'm not going to get into further details. So this is the baseline of a mouse, and when we stimulate the SI locomotor pathway, the animal had increased speed and had the ability to travel more compared to the baseline, as you can see. And then later, when we inhibit this pathway, the animal lost its ability to move, had decreased speed and significant less distance travel. Similarly, further gait analysis demonstrated increased speed after stimulation of this SI locomotor pathway in adult awake mice and decreased speed and movement when we inhibit this pathway. So the proposed SI locomotor pathway in this study is distinct from previously identified mechanisms of cortical locomotor control from the motor cortex and posterior parietal cortex, and provides a potential mechanism to directly and efficiently modulate movement according to sensory motor information. This data, we believe that add to a growing body of evidence suggesting that the primary somatosensory cortex, which receives and integrates information about our ever-changing internal and external environment, plays a significant role in the direct control of movement. I would like to finish by thanking all of our supporters in this work. Of course, my PhD supervisor and mentor, Dr. Michael Fehlings, my co-first author, Dr. Kajana Satkunatra, and various labs across the world for providing materials and experience throughout this work. Thank you very much for your attention.
Thank you so much, Spiros. Our second presentation will be provided by Dr. Tan Chen, and he is a clinical fellow at Sunnybrook Hospital as part of the U of T Spine program, and he'll be speaking on outcomes, comparative outcomes following lumbar disc arthroplasty, Canadian Spine Outcomes Research Network experience.
Can everyone see the screen?
Yes, I believe so.
All right. Hello, everyone. My name is Tan. I'm a Sunnybrook Spine Fellow. And I just wanted to thank the committee for giving me the opportunity to present my research here. So today I'll be presenting on the 2-year patient-reported outcomes following surgery involving either a lumbar disc arthroplasty or a spinal fusion secondary to symptomatic lumbar spondylosis. And this is just a quick acknowledgement to all the surgical attendings involved throughout the country, both in orthopedics as well as in neurosurgery, as well as to all those involved with data collection from the CSOR network. So as we know, low back pain has a lifetime prevalence of about 62 to 84% in the North American population. And one of the most common causes of low back pain is actually degenerative disc disease. Now, the mainstay of treatment currently for DDD is conservative, usually involving physiotherapy, core strengthening, rehabilitation, as well as medication. Now, when those all fail, the gold standard surgical treatment currently is still a spinal fusion. And spinal fusions are not without their own issues. they alter the they alter the biomechanics of the spine. They lead to increased stress on adjacent segment diseases, which leads to often a revision rate of somewhere between 10 to 20% over the course of 10 years because of adjacent segment disease. As well, because of putting in hardware, there could be issues with non-unions as well as hardware-related other issues. And so lumbar disc arthroplasties provide a more novel alternative to discogenic low back pain, in that it does, theoretically at least, it mimics the natural disc motion at that level. It theoretically should reduce back pain. It allows for functional motion, and then also should theoretically lower the rates of adjacent segment disease. Now, the current literature on this evolving technology, not surprisingly, is still quite out there. There have been some studies that show, similar functional outcomes between fusions and replacements. A lot of these studies are small, single-center studies, and oftentimes there are some commercial sponsorships and some bias involved. There are some older meta-analyses out there that show pretty conflicting information, whether or not there is an actual significant benefit or a non-inferiority between replacements and fusion. Now, currently in the Canadian literature, there's actually quite a bit of a paucity in terms of investigations looking at lumbar disc arthroplasties, especially compared to fusions, to the standard fusion cohort. And so that's essentially what we set out to investigate. We wanted to look and quantify and compare the long-term patient-reported outcomes following disc arthroplasties, and we wanted to compare that to a matched fusion cohort having a similar procedure, a fusion procedure of the same number of levels. And this, again, we wanted to do this through a multi-center Canadian perspective. So once again, so the methods, this is a multi-center ambidextrous comparative study. We collected data through the CSOR network from 2015 to 2019. Again, CSOR is a group of neurologic and orthopedic spine surgeons across Canada, over 50 of these guys. And currently our registry has over 10,000 enrolled patients. And so in terms of the selection criteria for our collection, so they have to have a chief complaint of low back pain. They have to have a main diagnosis of degenerative disc disease. They have to have undergone, so in the group of lumbar arthroplasty, they have to have undergone either a standalone primary arthroplasty or a hybrid technique where the construct is either one or two replacements plus a fusion segment. So either that, or they've undergone an isolated lumbar fusion, irrespective of technique, ALIF, OLIF, whichever. And so some of the exclusion criteria we had was, so no revision surgeries, no active infections, no autoimmune or chronic systemic diseases, and very importantly, no signs of instability, no spondies, no scoliosis, and no poor bone health. And so we took these groups and we matched them by the number of levels performed. So we matched patients who had a 1 level replacement to people who had 1 level fusion, 2 to 2, 3 to 3, etc. And then we compared their outcome scores and satisfactions from pre-op all the way out to 2 years post-op. So here are some of our patient results from patient demographics. So overall, in the replacement cohort, we collected 97 patients, 94 patients in the isolated fusion cohort. Our gender breakdown was relatively similar. There was a slight difference in terms of age. The replacement cohort was a couple years younger than the fusion cohort, but otherwise, the number in terms of comorbidities and BMI, they're all relatively similar. Here you can see in the top right corner, you can see the breakdown in terms of how many patients had 1 level, 2 level, 3 level, and 4 level surgeries. And importantly, it's important to note that in the disc arthroplasty cohort, that the from 2, 3, and 4 up, there's quite a few number of hybrids that are in this group. And then at the bottom, you can see this is a table of our collection centers. So most of these arthroplasty surgeries were being done in Quebec or in Alberta. And then to the right of the table, you can see all the different centers performing fusions for discogenic pain. So here are some results looking at the improvement in VAS back pain between pre-op and 2 years post-op. And so you can see the overall take home of this this table really is that there is no significant difference in terms of the improvement between LDAs and fusion cohorts, whether you look at break it down by the number of levels, whether you look at the whether it's like a hybrid cohort versus the fusion cohort, or a standalone one level versus isolated one level fusion. Everything has been exactly, there's no significant difference in VAS back pain. And then we look at VAS leg pain with exactly very similar results, no difference across the board. This is from pre-op to 2 years. And then we look at the improvements in ODI scores, very similarly, no difference across the board. There was one with the 2-level hybrids trending towards significance, but otherwise everything else has been pretty much not significant. We look at the satisfaction rates of these patients out to 2 years, and very similarly, the disc replacement cohorts had about 87% satisfaction rate, fusion cohorts had 82%. And here I just broke down the change or the improvement in VAS back pain from the pre-op point all the way out to 2 years. And you can see this agrees with a lot of the current American data out there, where it shows a improvement in like a hockey stick type trend, where both, so again, this is one level fusion against one level replacement. Isolated 2-level replacements versus 2-level fusion. So there are no hybrids in this group, and you can see all of these. They all show this nice trend, this hockey stick, where they all show they get significant improvement all the way out to 6 months, and then they maintain it all the way through to 2 years. And this is the amount of change. So this is minus 3.5 at this point. And then we do the exact same thing looking at ODI scores. Similarly, once again, a very similar hockey stick curvilinear type improvement. They all make significant improvements in their ODI scores at 6 months, and then a lot of these just continue to improve or start to plateau, but not really worsen out to 2 years. And so some of our study conclusions. So this is one of the first national multi-center studies in Canada looking at LDA outcomes. And we do believe that in the context of debilitating degenerative disc disease with back dominant pain, we do believe that lumbar disc replacements versus standard fusion, both of these techniques do meet the minimum clinical important difference in both ODI, VAS back, and VAS leg pain scores. And then they both show very comparative patient-reported outcomes and satisfaction out to 2 years. So some of the next steps for this study is that we want to go further. We want to look at even further long-term durability testing. And then we also wanted to look at the rates of revision surgery, which unfortunately was not included directly in the CSOR database. And so, one of the big rebuttals to lumbar disc replacements is that, people standards always say arthroplasties don't work. They end up fusing. Well, I think that there's a lot of new data coming out in the last 10 or so years with a lot of new technology that perhaps show otherwise. There's a lot of recent meta-analyses and RCTs showing that the VAS and the ODI scores are maintained out through 2 to 5 years, and there is another study in the pipelines all the way out to 10 years. And so this is one of the most popular studies that was recently published. This is a meta-analysis of 5-year outcome data looking at some of the whole slew of RCTs. So this is level 1A data comparing fusions versus arthroplasties for lumbar spine. And you can see that if you look at the rate of reoperation at the 5-year mark between fusion and replacement, this is almost like 100% difference. So in fusions, we have a 15% reoperation rate, whereas in the replacement, it's only 7. Then you look at the probability of ODI success and patient satisfaction, and both of these all are favoring disc replacement. And so that's kind of the take-home message from this talk. I think that to look at the future of where lumbar disc replacements are going, it's important to look at its nearby cousin, the cervical disc replacement. So if you look at the study at the very bottom, the graph at the very bottom left, so the red bar is the number of PubMed studies looking at cervical replacements The blue bar is lumbar disc replacements. And this is over the course of 3 to 4 decades. And you can see that the popularity of disc replacements, investigating cervical disc replacements, have only gone up. And I think with continued changes in technology, continued changes in materials, I think the popularity of disc replacements for lumbar spine will also improve. There's a lot of technology currently going on, looking at different types of viscoelastic implants, such as the M6 on the bottom right. There's different levels of constraint. There's different implant designs, even for level-specific, L4-5 or L5-1. And then also, it's really important, I think, in the setting of like a high-demand patient. Someone, like a golfer on the side who has had 2 discectomies and then an ALIF. Someone like that might potentially really benefit from such a replacement. Thank you so much.
Okay, so thank you so much, Tan. We'll be saving questions for the end, and so the next presentation will be given by Dr. Allam Martin, who's in the Division of Neurosurgery, as well as a graduate of the Surgeon Scientist Training Program, and he is a recipient of a prestigious Charles Kuntz Award for his research on the natural history of degenerative cervical myelopathy, as awarded from the AANS CNS section relating to spine. So thank you so much, Allam.
Thanks for having me. I just can everyone see my screen?
Yes, yes.
Perfect, thanks. I guess more importantly, I just want to begin with a tribute to Dr. Mainprize. Todd was a mentor and an amazing teacher, and I spent a lot of time with him, and it's a tragic loss, and my heart goes out to the family. So on that unhappy note, I'll just get started. So this is a study, an ambidextrous cohort study in 117 patients investigating the natural history of degenerative cervical myelopathy. I want to acknowledge my co-authors and also funding support through NREF this year as a clinical fellow and previously as a CHR fellow and various other organizations. It's a big team. So just primary degenerative cervical myelopathy is an umbrella term that encompasses all degenerative causes of cervical spinal cord compression, including CSM, OPLL, and disc herniations, etc. Clinical practice guidelines led by Dr. Fehlings that I got to be involved with recommend surgery for moderate or severe cervical myelopathy, but mild DCM is a bit ambiguous and controversial, and the group could not agree on optimal management. So surgery is an option, or non-operative management is an option, and then patients that show deterioration, we recommend surgery for. However, deterioration is a bit of a sticky point. What is the definition of deterioration? So we'll get into that. The natural history itself is also quite poorly characterized in the literature, and a number of studies I'll go through very quickly have a wide range of rates of deterioration over a wide range of follow-up periods. But some authors believe most patients deteriorate, and some authors believe almost no patients deteriorate. And if you speak to individual surgeons, you'll find that there's quite a lot of difference of opinion. So this is definitely a controversial topic, both in terms of optimal management and the natural history itself. So looking at the previous literature, there's this Kadenka randomized controlled trial, which is a very small trial. It was only 48 patients to begin with, and only 21 got surgery. And they followed patients out to 10 years. So there's a number of data points there. But basically, patients didn't get better with surgery, and they didn't get much worse without surgery. So the Japanese literature provides most of the insight into this condition, but they're a little more tilted toward OPLL. And they had a wide variety of rates of deterioration, range from 0 to 62% in various follow-up periods. So we really don't have a great picture of what the natural history is of this disease. Clinical practice guidelines, again, we recommended if there's deterioration that mild patients should get operated on. But what do we define as deterioration? So I'll get into that. So the study design of this was actually a prospective study that somewhat of a registry, and patients were enrolled prospectively, but then we did some retrospective chart reviews. We also collected quite a lot of clinical data prospectively, but ultimately for this particular study, we used clinical case definition of neurologic deterioration was the surgeon's assessment in clinic. So that encompasses subjective data and objective data from physical exam, and this was retrospectively extracted for this specific study. The quantitative clinical data, this is prospective data that we collected, was quite rich. So we collected MGOA, quick dash, grip strength, upper extremity dexterity, power, sensation, and we did electronic gait analysis with a pressure mat, looking at stability ratio and variability index. And I can talk offline about any of these if anyone's interested. And yeah, again, sensation. So we really tried to capture the richness of the neurologic deficits that occur in cervical myelopathy. So this is a big study. 182 patients were enrolled altogether. And in our cohort of patients that were managed non-operatively, we had 117 with follow-up data. So this was the analysis population, 117. 95 of these had a new diagnosis of cervical myelopathy, and it was their first visit to a spine surgeon. And then we followed them from that point onward. And of those 95 patients, 54 deteriorated within the follow-up period. And the median, the mean was 30.3. The median was 27 months. So it's just slightly skewed. But you can see the confidence interval, about half of patients, slightly over half of patients in 2.5 years will deteriorate based on this estimate. And then in patients with recurrent myelopathy, so these are patients that had cervical myelopathy that were operated on, that were doing well and then had new deterioration, new worsening of cervical myelopathy, and they were uniformly, all 22 patients had adjacent segment disease, and they were followed and managed non-operatively initially, and almost all of them got worse. So 73% got worse over the follow-up of 32 months as a mean. So you know, it does appear to be even more you know, poor natural history for patients with recurrent myelopathy. The pattern of deterioration we extracted from the chart reviews, and most of these were sort of a steady, more or less linear decline that was worse over months. Only one patient described a rapid decline over a period of less than 3 weeks. 3 had a clear stepwise history with sudden worsening, and 27 were subtle worsening. And these ones I think are the most interesting, because I do think quite a large number of these patients have a slow, subtle worsening that might get missed if you're using coarse outcome measures such as MGOA alone. We did plot a Kaplan-Meier survival plot for progression-free survival, but keep in mind that the data is limited here. This isn't complete data out to 60 months, so it looks quite bleak on this graph, but you need to view that with a bit of cynicism. So when we divided by severity category, severe patients and moderate patients had a greater rate of deterioration. So about 70% of those patients got worse, and about 50% of the mild patients got worse over the follow-up period. This is the 50 patients that had 2 or more quantitative clinical assessments. So this is the rich prospective data. We only got 50 patients to do this twice before surgery. Unfortunately, a lot of patients ended up getting surgery before we could book a second of these assessments. But this was really interesting data. So MGOA alone only was 2 points worse in 33% of patients that were deemed to be worse by the surgeon. Whereas a number of other measures performed a little bit better. So grip strength had 60% sensitivity and about 75% specificity for getting worse. So grip strength is an important measure. Dexterity had about 60 and 62% sensitivity and specificity. Gait stability ratio was pretty good, and gait variability index was pretty good. Now, as individual measures, none of these are really adequate as a standalone measure to determine if someone's worse. But when we try to put these together in a meaningful composite score, so this is a composite saying if 3 or more of these measures are worse by 10%, then the patient is worse. Then we start to make sense of all this data, and we get a measure that's 81% sensitive and 82% specific. So that seemed pretty good. Anatomical MRI does not get worse when patients get worse. So it was only 28% sensitive to detect deterioration. So the most common picture is someone gets worse, their MRI will look exactly the same. And it's not specific either. So it's only 70% specific for getting worse. So it's basically a useless test to monitor patients over time. It's useful to make the diagnosis of cervical myelopathy, and it's useful for surgical planning if you're going to operate on it. But these patients that get 15 MRIs over the years, and we had a few of those, there's really no need to keep ordering these MRIs. So limitations, this is mostly a retrospective analysis, although some of the data was prospective. The clinical case definition is somewhat subjective, and there's a risk of confirmation bias. We would have liked to have these quantitative assessments in a bigger group, and clinical measurement, no matter how you do it, is confounded by comorbidities. So, for example, MGOA is affected by if you have symptomatic lumbar stenosis or another neurologic or orthopedic condition. So it's hard to do clinical measurement, and I think that people who do it understand that. The conclusions are that the natural history does appear to be quite poor, and you know, I do think it justifies early surgery for myelopathy, but prospective data is needed to validate this. MGOA is insensitive alone and is useful in combination with things like grip strength, dexterity, gait, and balance. And anatomical MRI alone is not that useful, so don't keep ordering those tests. Thank you.
Thank you so much, Alan. That's great work, and very important and of relevance, obviously, in terms of our management of these patients who often present sort of with imaging findings and may have very subtle, if any, sort of symptoms. Our next presentation is by Colby Oitment, who is also a clinical fellow in the U of T spine program at the Toronto Western Hospital, and he is going to provide a bit of an update to us on strategies as it relates to contouring rods in adult deformity surgery. So thank you so much, Colby.
Thanks for having me, and thanks, Alan. That was great. So I'm just going to start off here with how to bend the rod. So first of all, why does it matter? And what we know is that if you have a deformity in the spine, the rest of the spine becomes deformed as well around this. And you can see here, for example, a patient with congenital kyphosis around the thoracolumbar region really has a compensatory thoracic lordosis, and the deformity spans the spine. And with correct contouring and an appropriate correction of the deformity, there's really restoration of normal sagittal alignment throughout the remainder of the spine. Similarly, if you take a patient with, here we have a patient with fixed lumbosacral kyphosis, and you can see again compensatory lordosis throughout the thoracic spine and a cervical thoracic swan neck, and he's really working hard to stand up, and so correction of this as well really leads to a much more normal appearance of clinical photograph as well as his x-rays. And finally, just another example of a patient here with Scheuermann's kyphosis, a young lady with correction you can see in the postoperative films and clinical photograph, really restores not just the thoracic spine, but the lumbar spine and the neck as well. And so the question today for this presentation is, what are the principles of rod contour that we can apply so that we end up with a nice looking x-ray, as you see on the left, with a restoration of sagittal balance, and avoid the problems that you see in the middle and on the right. So to answer that, we really need to restore sagittal balance. And the question is, well, what's the shape of the spine? And we know that chronally the spine is straight, and that's not very controversial, but sagittally the spine has different contours, and it's been controversial in terms of how much curvature and where that curvature becomes the next region. For instance, how much lordosis and that inflection point between lordosis and kyphosis, this has been a source of debate. So as it turns out, the shape of the spine is determined by the shape of the pelvis, and the morphology of the pelvis in the equation you see on the screen, the PI refers to pelvic incidence. And we know that pelvic incidence is equal to tilt and slope, but what does this actually mean? Well, if you look at patients with a low pelvic incidence, as you see on the left, they've got less sacral slope, and so they've got less lordosis, and their spine is overall much flatter compared to a patient with a high pelvic incidence, as you can see on the right. And this patient has much more lordosis, and they'll have much more kyphosis at the top as well. And so when we look at the pelvic incidence in relation to overall shape, the take-home message is that more pelvic incidence equals more lordosis. And we can see, this is from the studies of Pierre Rousseli, and we see that the type 1-2 are really the patients who have lower pelvic incidences. And so there's a couple different morphologies the spine may take on, and type 3 and 4 are really the higher pelvic incidences. And you can see there's quite a difference in appearance. And so we know that more lordosis is associated with the higher PI patients that we should consider. The question is how much lordosis then? And so when we study the lumbopelvic mismatch that's tolerated, 10 degrees is really appropriate for younger patients. And in the elderly, if you shoot for 10 degrees, you're really overcorrecting them, and it leads to early mechanical failure. So we aim for much more modest 15 to 20 degrees correction. And so just for an example, if you take a patient, a younger patient, a 25-year-old female with a PI of 50, she's going to need roughly 40 degrees of lordosis. And if you take the same patient at the age of 70, you're going to need roughly 30 to 35 degrees of lordosis. And so finally, we have an idea of how much lordosis is put in the rod. The question is, where do you put the lordosis? And we've shown repeatedly through the segmental analyses of the spine that almost all the lordosis is in the bottom of the curve. So this is a picture from Bernhardt Bridwell's study from the late 90s, but it's been shown repeatedly. Most of the lordosis is in the distal third from L4 to S1, and a minority is in the top of the lumbar spine. So your rod contour should really reflect that by placing it at the bottom. And so we have an idea of how much lordosis and where to put it in the rod. The question is, where does that rod transition to kyphosis? And not everyone has this thoracic spine starting at the 12-1 disc space. And so this concept of where lordosis becomes kyphosis, studied by Pierre Rousseli, has been termed an inflection point. And what we know is that patients with lower pelvic incidences have inflection points in the lumbar spine. And if you look at patients with higher PIs, type 3 and 4 in the graphs at the bottom, they've got inflection points at either the thoracolumbar junction or even in the thoracic spine. And what we know is that if you fuse a patient with an inflection point in the thoracic spine or even close to the junction, the mechanical failure is very high, and so are the rates of PJK. So we use this information to guide us to say that we should probably bend the rod with an inflection point around the L1-2 disc space would be safe. And finally, our goal is to restore the overall alignment. So first of all, how do you even measure that? The simplest way would be to use the SVA. So if you draw a C7 plumb line, that's just a point in the C7 body at the center, draw it straight down, it should bisect the posterior superior corner of S1. And the further the patient is off that line, you can measure that distance, which we call the SVA, but we know that patients who are more than 5 to 7 centimeters off that line work really hard to stand upright. And so your sagittal contour should take into consideration what's needed to bring this patient back to normal sagittal alignment. And so in summary, our rod contour principles today are that lordosis depends on PI, and most of the lordosis is distal in the rod. A minimum amount of that lordosis should be at the top of the lumbar spine. Your inflection point should be at L1-2, and you should restore the sagittal balance. So just a couple of cases to illustrate these points. Case 1's 59-year-old female with degenerative deformity, coronal sagittal malalignment. And what you can see after the surgery, we've got a nice rod contour here, coronally sagittally aligned. We've got age-appropriate lumbopelvic mismatch. We've got an inflection point at L1-2, and most of the lordosis is in the distal rod. And there's less proximally. So in my opinion, this patient, this is a winner. Case 2, this is a 40-year-old female with a lanky 5 adolescent idiopathic deformity, coronally imbalanced, so off to the left there with a high inflection point on the lateral x-ray. You can see that inflection point in her spine is up around the T11-12 disc space. And so when we contour the rod, our goal was to bring that down. So it's through rod contour and releases that we're able to place that inflection point down around the L1-2 disc space. We've leveled L4s, we've got nice coronal sagittal balance, and so this patient also a winner. This patient, unfortunately, you can see here is an adult degenerative deformity patient who post-operatively, we've got a very high inflection point, overcorrected, and this patient, unfortunately, has gone on to early PJK and proximal hardware failure. Some other examples here, you've got on the far left, you've got a patient with a straight rod, a lumbosacral junction, so relative lumbosacral kyphosis, a positive SVA. This patient's really leaning back, trying to maintain upright posture, so this is not a winner. We've got a short segment fusion here, and the fusion itself doesn't look too bad, but you can see that the L4 to S1 contour really isn't reestablished, so there's really not much lordosis there, and you can see in the proximal lumbar spine here, the disc spaces are gapped, and the patient's really working hard again to maintain that upright posture. So again, this not ideal. And finally, we've got a patient with a very low inflection point, obviously broken rods, straight spine, straight rods above that. So again, less than ideal. So the take-home points today for rod contour are that the amount of lordosis depends on PI, and we've got our age-corrected goals for line there. The location is that 2/3 of the lordosis should be in that distal arc from L4 to S1. You should ideally transition at the L1-2 disc space, and then your goal should be to restore normal sagittal alignment. Thank you.
Okay, thank you so much, Colby. And so we'll, I guess, head on to the discussion period. And so I think for those that are panelists, you're able to open up and ask questions. We also have a few questions on Q&A, and then time permitting, we may also use the raise the hand function for those that are attendees as well. So I guess, Professor Studley, is there questions you'd like to start off with, or I can...
Thanks, Albert. I really enjoyed all those talks. Fabulous work. My first question is for Dr. Oitment. How much work do you do preoperatively in terms of preparing the rod shapes? And do you use 3D printing at all to help prepare the rod shapes?
During our fellowship, we haven't used any 3D printing. I think mostly it's just preoperative planning in terms of knowing what segments you need to release, where you're going to get your correction from, and then essentially appropriately bending that rod. And I think positioning preoperatively as well, like if the spine's mobile and you've got them on the bolsters and their lumbar spine droops down, it's very easy to just place a rod in that overcorrects them. And we think that can lead to early failure as well. So I think it's mostly just planning in terms of where you're going to get your releases, where that correction's coming from, contour the rod, knowing where you're going to transition that inflection point.
Thank you.
Colby, as a bit of a follow-up to that, I guess any pearls or thoughts? You sort of mentioned, basically patient positioning. These can be very lengthy procedures. You spend a lot of time doing your releases and or osteotomies for fixed deformities, and I guess choice of bed positioning, intraoperative X-ray to gauge that sense of alignment before you quote unquote lock them in.
Yeah, exactly. I think if you're not sure, you definitely get an X-ray, and then you have to just again double check it before you lock them in and fuse them in that position, because it's a much bigger job to take them back later and try and fix it. So,
a question for Tam, which is actually drawn from the faculty, and this is actually Dr. Amendolia's a question, and I think these were prospective, non-randomized cohort studies. So I think Dr. Amendolia's question kind of related to the absence of a control group. If you could perhaps comment on that, and then what kind of a population of patients were these? Were these isolated back pain, or did these patients have a significant contribution of leg pain? Because those are really different types of patients.
So I guess I'll start with the first part of this. So one of the big limitations to this, we're pulling all of this from the CSORN database. And so we don't have a direct control group that we can compare kind of the natural history throughout those 2 years. With regards to the second question, sorry, what was the second? Could you repeat that second one again?
So the first one had to do with kind of the absence of a control group and just trying to define the cohort. And then the second question really relates to, were these patients a group with pure axial back pain, or did they have a strong component of leg dominant pain? Because these are really kind of different groups of patients.
Right, so that was actually one of our big selection criteria. You know, of course, this is still within the realm of being limited by this database, but we focused on patients who their chief complaint has to be back dominant pain, and their main diagnosis cannot be disc herniation or radiculopathy. It has to be degenerative disc disease. So it has to be focused mainly axial back pain.
Thank you.
And I guess, Tan, is a bit of a follow-up to that. It sort of dovetails around the question of the pain generator, which was sort of brought up as well. And so, you know, how do these constructs, you know, relieve pain from a structural anatomical perspective? And, you know, particularly if you're talking about a 3-level procedure, you know, could you maybe just highlight a bit of the decision analysis for patient selection, you know, recognizing that this is sort of a subgroup of surgeons around the country that tend to sort of specialize in this area and have very sort of discrete screening and eligibility criteria.
So, I mean, from what I understand, the screening criteria for a patient to actually get a disc replacement is actually quite rigorous. You know, in general, so they have to have, usually they're relatively younger and they're healthier. They have to have good bone quality. So a lot of these patients are getting pre-op DEXA scans. Some of these patients actually get Forteo post-op. Usually there has to be a certain amount of disc space that, you know, every surgeon is a little bit different, but some say, you know, 4 millimeters, 5 millimeters, 6 millimeters. There has to be a good amount of disc height left. And, you know, usually they just, I think like in terms also from the back, usually there has to be very mild to none facet hypertrophy. So almost no posterior degeneration. And it has to be really kind of, you know, once you start filtering all of these patients, I think the number of eligible patients really starts to wither. In the States, a lot of the surgeons who are doing these disc replacements, they often do get a discography preoperatively, and they just see, you know, if the patient does make a significant improvement with this injection, then at least we know where exactly the pain generator is, and this is not the pain generator, like it's not a pain that's coming from somewhere else that's kind of just maybe masking, and we're kind of thinking that, you know, they might have like a concurrent you know, dry disc, but that might not be where the pain is coming from. So I think the selection criteria is quite stringent in terms of actually ending up with a arthroplasty.
Okay, so
there was another question actually from Dr. Amendolia for Allam Martin. And Allan, the question kind of relates to this group of patients with degenerative cervical myelopathy that were managed non-operatively. Can you comment on the type of non-operative management that they received, and did they receive structured rehabilitation?
Yeah, so that's a great question. That was not part of the data that we specifically collected. It was, we discussed it, but we didn't have enough data to really analyze that because that wasn't collected prospectively. So I think that that's an important consideration for future trials. You know, the part of this study was largely initiated by Sukhvinder Kelsey Ryan, and you know, she's a physiotherapist with an interest in non-operative treatments, but you know, we just I think probably about a quarter of these patients did have some structured rehab, and another half probably had some unstructured rehab, but we don't have exact data, and that wasn't part of the analysis. I think that's a great point to look at for future studies, and it's a big gap in the literature, really.
And Alan, as a bit of a follow-up, you know, we're sort of in this very interesting time where we're looking at, you know, what our sort of new normal may look like and how we sort of screen and assess patients. And so, you know, with the advent or I guess resurgence of virtual abilities, I mean, how would you, Mike, recommend, you know, those of us, you know, with these sort of patients in terms of following them over time? You're suggesting maybe imaging may not be necessary. You know, do I need to bring them in and check their reflexes? What can be done virtually? And do you have any thoughts or suggestions for us as we think about that population?
Yeah, no, I think that's interesting. I think 3 months ago, I would have told you that physical exam is really important. And I also, my belief is that most patients know if they're getting worse. So that subtle subjective sense that patients are getting worse, most patients are able to recognize it. So I'd say it's a vast minority of patients that don't recognize some subtle changes occurring and that you pick up with your exam that they would have missed. But, you know, instruments like the MGOA are actually pretty coarse. So there's only 4 levels for sensory function: normal, absent, mild, or severe. So a patient can go from mild to slightly more mild and their MGOA doesn't change. And a lot of patients don't have trouble picking between mild and severe sensory dysfunction. So, you know, having greater gradations perhaps, or actually creating a new questionnaire that's really about changes in your symptoms and looking at each of those systems and asking, is there a change in your hand dexterity? Is there a change in your sensory dysfunction? That, to me, those are the questions I ask in real life, and they usually capture the answer. So I'd say 80 or 90% of the time, in my experience, patients recognize that they're getting worse. And it's usually that reporting combined with some physical exam to confirm it is the best way.
Thank you, Alan. And I guess just to complete things with Spiros, a very fascinating talk and great work. I noticed a bit of a chat relating to the clinical relevance of some of these circuits and whether or not it may explain some of the gait findings in some of our myelopathic patients. And so can you maybe expand a little bit upon, you know, the translational relevance of some of your work as it relates to either diagnostic or therapeutic perspectives? And are there interspecies variations in terms of the circuitry that we may need to consider as well?
I think Spiros may have fortunately had to leave the call. So maybe as his PhD supervisor, I'll take a stab at answering the question. So the clinical relevance actually relates to the question of, you know, why do patients with cervical cord compression from degenerative cervical myelopathy present with a gait disturbance as their first symptom? That's the usual situation. And we wondered whether there was a population of neurons in the cervical cord that might mediate gait. And it was really that question. And so when we started doing the tracing experiments, optogenetics and so on, we found to our surprise that there was a direct connection from the somatosensory cortex into this population of excitatory cervical interneurons and then going down to the lumbar central pattern generator. And it appears that there's a component of sensory feedback, which we know is important for motor control. But when you're assessing a gait function, this may actually impact on the way you know, people kind of navigate a complex terrain when they're walking. And so they may do better on a smooth terrain, but may have more difficulty where there's a lot of sensory feedback that's required. And then it may also kind of have an impact on rehabilitation protocols as well. So efforts, for example, to work on sensory feedback may actually have an impact on motor circuits. So Spiros, I hope I did a good enough job of answering the question for you, but just pinch hitting.
Very interesting. Thank you. I guess at this time we will segue to the next section, a couple of talks and award presentations. I guess we have a bit of a slide deck to acknowledge basically, and this is for Professor Studley's sort of reference. We usually have an open call for abstracts, and it's sort of adjudicated by a panel. So Michael and I would just like to acknowledge the individuals that participated in the abstract adjudication. There are links to the East poster and judgings with voice threads that folks are able to follow, which is a great format just to see some of the discussions that occurred around some of the poster presentations. I guess, Michael, I may turn it over to you to introduce the high-scoring oral presentations arising from the abstracts, James Kahn being the first speaker.
Thank you, Albert. And this is really a big highlight for all of us as faculty to see our students and trainees excelling. So the first talk will be by James Hong. And James has examined the role of remote ischemic preconditioning to reduce ischemia reperfusion injury following decompressive surgery for degenerative cervical myelopathy. James, over to you.
Good afternoon. Actually, almost close to good evening, and thank you for the committee for the opportunity to speak today. I'm going to be talking to you today about an exciting study that looks at using a non-invasive approach known as remote ischemic preconditioning as a prophylaxis for ischemia reperfusion injury caused by degenerative decompressive surgery for degenerative cervical myelopathy. Degenerative cervical myelopathy is the most common cause of spinal cord impairment globally. It is caused by age or genetically related changes that result in narrowing of the spinal canal, as shown by this MR on the left, which leads to chronic spinal cord compression and neurologic disability. The current clinical practice recommends surgical decompression for patients with severe or moderate DCM. As Dr. Martin has alluded to, of these patients, 9.3 of them will exhibit neurological deterioration within 6 months. 44% of these patients continue to have residual impairment. DCM has an ischemic component. A cervical cord compression over time results in endothelial cell dysfunction, regional malperfusion, and local deformation of vessels. These changes to the vasculature then result in ischemia, which contributes to neuroinflammation and apoptosis of neural tissue over time. Decompression is the current standard of treatment for DCM. However, our lab has shown in both human and rodent models of DCM that decompressive surgery results in acute ischemia reperfusion injury. This injury is characterized by an increase in intraspinal blood flow 24 hours post-decompression and increases in markers such as 8-OXO-G, oxidative markers inside neurons, inflammatory cytokines like GCSF, IL-6, and CXCL10, as well as an increase in the influx of monocytes to the spinal cord. In our particular model of DCM and RIPC, or remote ischemic preconditioning, we use 3 cycles of 5 minutes of cuffing in the hind limb of the mouse, followed by 4 minutes of reperfusion or recovery. Remote ischemic preconditioning is a non-invasive intervention that uses repeated short bouts of ischemia or reperfusion prior to the insult and distal to the site of injury, usually in the hind limb or forelimbs, to protect organs against IRI. It's known to act through both humoral and neural mechanisms and has been shown to decrease immune cell infiltration and apoptosis following ischemia reperfusion. So Due to the potent protective effects of RIPC that has been demonstrated in other models, we aim to test this as a prophylaxis prior to decompression for DCM. We hypothesize that RIPC will mitigate IRI-associated pathology and enhance functional recovery following DEC for DCM. To do this, we induced DCM in black 6 mouse and let it progress for 12 weeks. At week 12, we subjected them either to a sham surgery without laminectomy, which is our DCM control, decompression, DEC, or RIPC prior to DEC. These animals were kept alive for either 24 hours, which is our acute time point, or 5 weeks, which is our chronic time point. In each of these time points, we collected their behavior starting from week 4, when DCM symptoms begin to present, to their respective endpoints, and we had identically sized cohorts for both molecular immunohistochemistry work. Firstly, we looked at albumin accumulation in the cord 24 hours post-DEC, and similar to the previous work, we show that after decompression, there's an increase in intraspinal albumin. RIPC mitigates that. We also show that RIPC significantly reduces the amount of Cleese caspase-3, which is a marker of apoptosis relative to total caspase within the cord compared to DEC alone. And further, RIPC also acutely reduced the protein expression of multiple inflammatory cytokines in the spinal cord, while DEC clearly elevated it relative to DCM alone, as shown by the red here. As mentioned before, we tracked the gait of animals starting at 4 weeks post-DECM, N of 200, and continue to track chronic animals 5 weeks post-surgery in their respective cohorts. The dotted line here represents the point at which they received surgery, either sham surgery, decompression, or RIPC plus decompression. And we show that chronically, RIPC with decompression resulted in drastic improvements in multiple gait parameters compared to DEC only. We saw this in body speed, stride length, cadence, number of steps, stand duration, as well as swing speed. It's worthwhile to note that to date, this is the most significant improvement in gait that's been demonstrated in any rodent DCM intervention. To further investigate the underlying cause of RIPC-mediated improvement, we perform RNA sequencing. We show that RIPC results in over 1,000 transcriptional level changes relative to decompression alone. Of these, we saw massive downregulations in 2 long-chain non-coding RNAs that have been known to be biomarkers for ischemic injury, in addition to several upregulations in genes related to lysosomal degradation, including LYS2 and complement 1QA. Using functional enrichment, we show that the majority of genes upregulated after RIPC had to do with lysosomal degradation, autophagy, and glial cell activation. To summarize, RIPC reduces blood accumulation in the cord, reduces neural inflammation and apoptosis, enhances functional recovery 4 to 5 weeks post-decompression, and upregulates several pathways related to autophagy by glial cells and infiltrating monocytes. RIPC is a non-invasive approach and can be translated rapidly as a prophylaxis for DEC. Some future work include completing the immunohistochemical assessments of the tissue and cellular changes following RIPC, and investigating the role of autophagy as a mechanism of action, and the role of these long non-coding RNAs in DCM ischemia. And this is just to acknowledge some of the co-authors of the work. Thank you very much.
Thank you, James. So we'll hold questions until the discussion period. Thank you very much. So in the U of T spine program, we enjoy a multidisciplinary collaboration amongst a broad group of disciplines. And one of the groups that we enjoy a strong collaboration with are the oncology group, in particular the radiation oncology group. And I'm pleased to introduce our next award winner, Dr. Ahmed Abugharib, who will be speaking on imaging-based local control outcomes specific to spine stereotactic body radiotherapy, or SBRT, for prostate cancer metastases. Ahmed.
Good afternoon. I am Ahmed Abugharib. I'm a clinical fellow in the Radiation Oncology Department, Toronto University. First of all, I would like to say that I'm really sorry for the sudden loss of Dr. Mainprize. Actually, I never met him, but I knew from my mentor, Dr. Ajun Segal, that he was a great man and a great colleague. Okay, my presentation is about the use of SBRT for the treatment of spinal metastasis in prostate cancer patients. And this study was conducted under the supervision of Dr. Arjun Segal, Professor of Radiation Oncology at Toronto University, and Dr. Jay Tedeschi, Assistant Professor of Radiation Oncology at Toronto University. Okay, first of all, I would like to say that there has been an increase in the incidence of cancer because of the screening programs, better diagnostic tools, and also because of the better access to health services, particularly in the developing countries. And since mid-70s, there have been a prolongation in the cancer survival, especially in the recent years with the development of target therapy. So both the increased incidence of cancer and improved survival led to an increase in the percentage of cancer patients diagnosed with metastatic disease. As you all know, bone is considered one of the most common sites for the metastasis following the liver and lung. And about 40% of cancer patients will develop spinal metastasis either at presentation or during the course of the disease. And these spinal metastases usually present with pain, vertebral compression fracture, and or epidural disease with spinal cord compression, which develop in about 10 to 20% of cancer patients with a spinal metastasis. So when we are dealing with the treatment for spinal metastasis, first we need to know what is the aim of our treatment. Do we need to control symptoms and prevent any neurological complications, or we can eradicate the metastasis and improve the survival in cases with oligometastasis? So once we decide the aim of our treatment, we can choose between one of two treatment options. The first option is to go for surgery, which is the main approach if the spinal stability is in danger, or if there is significant neural decompression, or after the failure of radiation therapy. The second option is to go for radiation therapy, which is considered the treatment of choice for the spinal metastatic lesions. However, in certain circumstances, we have to use both surgery with a pre or post-operative radiation therapy to control the spinal metastasis. So right now, if we decided to go with radiation therapy, which one we should use? The blue cold treatment, which is a conventional fractionation, or the red hot one, which is SBRT. Actually, traditionally, conventional fractionation has been the treatment of choice for those who are not eligible for surgical intervention, and the conventional fractionation managed to achieve pain relief and local control of the disease in about 60 to 80% of the cases. However, these results were not satisfactory, especially when we are dealing with a bulky lesions or metastatic radioresistant or metastasis of radioresistant nature. So we required another treatment option, which is the SBRT. SBRT manages to deliver high biologically effective dose to the spinal metastasis without affecting the surrounding organs at risk, in order to reach a better and faster pain relief, and also to achieve longer control rates of the local disease. And in our study, we used the SBRT for the treatment of prostate cancer patient with spinal metastasis. And we had a prospective data, which was retrospectively reviewed. And we identified 185 spinal segment lesions in 94 prostate cancer patients who was treated with SBRT. So, and the primary endpoint of our study was to know the local control rates that can be achieved with SBRT. and also to know the overall survival and the vertebral compression fracture, because in other studies like the one published from Memorial Sloan Kettering, the vertebral compression fracture following the SBRT treatment of spinal metastasis was high, up to 38% of the cases. Right now we can see the patient characteristics, and most of our patients, like about 86%, were ECOG ECOG 0 to 1. I mean, they had a good performance and with a normal neurological status. Oligometastatic disease patient were 74%, it's about 3/4 of the patient, and lung metastasis and liver also metastasis wasn't like in a high percentage of the cases, and about 94% of the patients were free of metastasis except for the bone mets. And about 50% of the patients were castrate resistant, and about 82% of the 87% of the patients didn't receive prior external beam radiotherapy. However, about 13% of the cases received external beam radiotherapy to the same segment that was treated with the SBRT in our study. As regards the tumor characteristics, 70% of the spinal segments were de novo. I told before that we included 185 spinal segments, and 131 of these spinal segments were de novo. I mean, these segments didn't receive any treatment before, either like operation or radiotherapy. And the fractionation used in our study was 24 to 28 gray in 1 and 2 fraction for about 75% of the cases. And we used also another fractionation for the remaining 25%, which is 25 to 35 gray in 3 to 5 fractions. 65% of our patients didn't have any epidural disease, and also 50% were pain-free. And it's usual, like 65% of the patients had like plastic metastasis because they are prostate cancer patient, and as you all know, the prostate cancer patient is mainly plastic or mixed. And the results of our study showed that the local control was actually like very beautiful for the patient with a spinal metastasis received SBRT, and the local control at 1 year was 97%. 2 years and 3 years was 92 and 82% respectively. And as you can see in the graph here, in the blue one is a cumulative incidence of the local recurrence for the prostate cancer patient. And actually we tried to compare between the prostate cancer patient cohort and another cohort of patient with spinal metastasis, but from a radio-resistant nature. And this cohort included a patient with spinal metastasis from the primary, like renal cell carcinoma, melanoma, sarcoma, and thyroid colon cancer, which are considered radio-resistant. And we can see that the local control is very high in case of prostate cancer patients, up to 97%. The overall survival at 1 and 2 years was 90.8 and 81.4%, and we didn't expect that the SBRT treatment will affect the overall survival. We just happy that it's affected the local control and it's achieved a very high local control. So some can say that the SBRT treatment is a very hard treatment and it can achieve the local control, but it will cause high percentage of vertebral cord compression as that results which was published from the Memorial Sloan Kettering. However, our results showed that the vertebral cord compression is not that high, and it's about the 5% at 1 year and 12.6% at 2 years, which is a really good result compared with that published from the United States. So the conclusion of our study that SBRT provides an excellent control of spinal metastasis in prostate cancer patient with a very low risk of vertebral compression fraction, about 12%. And the question that need to be answered in the future, that can SBRT considered as a curative rather than a palliative treatment when we are dealing with oligometastatic patient, and this patient, if we can like give high dose of radiation to eradicate the disease, and this is the only site of the disease, will this like improve the survival of the patient, which has been already published in a phase 2 trial, and the SBRT in this trial showed that there is improved survival in the patient who had the SBRT for oligometastasis. And the second question is, we need a direct comparison between the SBRT and the conventional fractionation from the treatment for the spinal metastasis. And I think we need to wait for the result of the CS24 trial to know which one we can use in the future. And thank you.
Thank you, Dr. Abugharib. And perhaps Professor Studley, if you had any questions, we might give you the first go.
Yeah, thanks, Michael. Again, I really enjoyed those talks, and I have a question for James. Do you think it's possible that if you identify the agent responsible for the preconditioning, that it might prove even more effective if you could administer that systemically rather than actually inducing ischemia?
Great question. I used to work in a lab at SickKids that looked at identifying the agents, the humoral agents responsible for RIPC. It was a very difficult study that was undertaken, involving a lot of proteomics as well as mass spectrometry. They managed to narrow it down to it being something that's less than 15 kilodaltons that was responsible, which could be pretty much very small peptides like heat shock proteins, to just it being a combination of chemicals that are being released. And they later found out there were some studies done looking at C fibers and how chemicals, essentially neuropeptides that were being released from the C fibers could be responsible for RIPC. It's worthwhile to note that RIPC works if you dialyze an RIPC animal and essentially infuse another animal with the dialysate. And so it does work if you were to administer it in that way. It's pretty much less invasive if you just go with the approach of and doing the cycle of RIPC right now with the forelimb, which they do for patients undergoing cardiac transplants as well as kidney transplants. And it's as easy as using essentially a blood pressure cuff to administer the RIPC.
Okay, thank you.
A question for Dr. Abugharib. So what currently is the preferred protocol in your unit for an oligometastatic spine lesion? Would you still prefer the combination of surgery and then perhaps stereotactic radiation, or do you think that stereotactic radiation alone might be a reasonable option?
Actually, we are using the combination of treatment, like using the surgery with a pre or post-operative radiation therapy if the patient already have like significant epidural disease and we need spine cord decompression before going to radiation therapy. Because if there is like significant epidural disease and it's compressing the cord, we can't deliver the high dose to the tumor without affecting the spinal cord itself. So we need at least like, if we have a significant epidural disease, at least decompression operation, then we can go for radiation therapy. Also, we can use, the combination treatment, the surgery plus radiation therapy, if there is spinal instability. At this case, we need surgery first to stabilize the spine, then we can go for radiation therapy. And however, if we don't have like significant epidural disease or the spine is stable, we can go directly for radiation therapy. And in case of the metastatic patient, we prefer to use the SBRT because it provides a longer control and it can be used like for treatment, for disease eradication, not just a palliative treatment.
Thank you very much. I think perhaps for sake of time, because we're just a little bit over, that maybe we'll end this a session and then might call upon Dr. Yee again to assist me. We'll do this together in terms of some special awards. And Nadia and Terry, I think we have some slides. Again, a big congratulations to all of the trainees for outstanding talks, and I think that the trainees contribute greatly to the clinical and the academic milieu of the University of Toronto spine program, and I think the presentations highlight the rich environment. Albert, did you perhaps want to recognize our award winners again?
Sure. And so I'd echo those sentiments as well. I mean, these are tough times, and we're working through this together. And it's really, the frontline individuals that include the residents and fellows who are honestly in person, often on call, and putting themselves at risk as well. And so. We've also had trainees that have been redeployed to other service areas during this period of time as well. So I really do want to acknowledge all your valued contributions on all fronts of academic efforts. And so congratulations again to the first and second place best abstract winners. So Dr. James Hong and Dr. Ahmed Abugharib. And to our invited trainees, Dr. Spiros Spirondan, Dr. Tan Chen, Dr. Colby Oitment, and Dr. Allam Martin. And this year as well, one of the sort of new awards that I think we've established is, recognizing that, we have, 4 centers around the city that have key clinical and or research activities relating to spine. And many members of our program council and faculty that contribute towards our academic counter events throughout the year, that we'd establish a bit of a special recognition award in terms of recognizing a particular faculty member that has gone above the call of regular duties to really help out and provide a tremendous value to our programmatic offerings. And so, without further ado, Michael and I would like to acknowledge and thank Dr. Stephen Lewis as this year's recipient of the Special Recognition Award from our program. Dr. Lewis, or Steve to many of us, has been a long-standing contributor to our program, very passionate, energetic in terms of education and teaching, and has put on a surgical skills course, which has been a tremendous value add to many of our trainees over many years. And this year, being no exception, really hosted this course during challenging times, and was one of the sort of initial test case from the surgical skills facility at the Mount Sinai Hospital as we went through a whole new process and protocol for ensuring safety, yet providing time for folks to be exposed to the cadaver labs for the anatomy and technical skills training portion of things. So thank you again, Steve. And maybe if you'd like to say a few words, I'd be happy to open up the virtual podium at this time.
No, thanks a lot, guys. That's really nice and very appreciative. The fellows are really kind of the key things why we're doing all this training. And this year we really had a group of special fellows that really made it a pleasure to engage. They've been very passionate. They've been so keen on learning, and They really fought hard to get our skills lab working today. I've never seen a group so keen on trying to get as much knowledge and skill to really complement what they have in their knowledge and skills, so they can go home and get the skills that they need. Sorry for my daughter.
Well, a big shout out to you, Steve, and you've organized the Fellows course for a number of years, and we want to this award has probably been a bit overdue because you've really contributed substantially, and just want to thank you. And, Albert and I also want to express our appreciation to Nadia Jabber, who has, in addition to organizing our virtual SpineFest just a week prior to this, helped Steve to organize the hands-on spine course, which was done in a very, very innovative and unique way, and I think it may have actually been the best course to date. We'll see what the evaluations are, but certainly is very special. So thank you very much, Steve and Nadia.
Thank you. Thank you. We've been actually having really good feedback about the course from the fellows. Very, very positive.
Okay, thank you. Just before we close, just a huge debt of gratitude to Professor Marcus Studley, who's been an outstanding guest professor, our Tatter Turnbull guest lecturer, and you know, we would have of course loved to have hosted you in Toronto personally. These are extraordinary times, and it's very gracious of you to have contributed your time and expertise. Your lectures yesterday were outstanding, and we appreciate your participation today in the discussions, and we look forward to your contributions a little later for our celebration of the Spine Fellows graduation. And Albert, perhaps final closing thanks over to you.
Yeah, so thank you. And you know, I think you know, this is a bit of a new experience for all of us, and I think just sort of keeping in line with what we have tried to organize. Over the next a few minutes, Nadia will provide the link for the e-poster viewings and thread for those that would like to take the time to sort of see some of the e-posters. And we plan to reconvene at about 7 o'clock for those participating in the GTA rounds that we chaired by Dr. Joel Finkelstein, and we'll be having a little bit more of acknowledgement of the clinical fellows upon their graduation at that time, along with the fellows supervisors. So many thanks again to everybody, to the university, as well as our industry sponsors for all the support over many years. And be safe, be well, and until soon.
Thank you, everyone.